On behalf of the American Heart Association, I would like to welcome you to today's webinar, From Evidence to Practice, Bringing a Cardiovascular Kidney Metabolic Model of Care to Life. My name is Renee Sednew, and I am a National Director in Clinical Research Services here at the American Heart Association. Before we begin, I'd like to go over a few items to help you use today's platform. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's program, you will have the opportunity to submit text questions for our presenters using the Q&A feature from the toolbar at the bottom of your screen. You may send in your questions at any time, and we will review them during the Q&A session as time allows. A copy of the presentation is available for download in the resources section located at the bottom of your screen. Finally, today's webinar will be recorded and sent to all participants in a few hours following the live event. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association, American Stroke Association. The American Heart Association, American Stroke Association does not endorse any product or device. The American Heart Association's Cardiovascular-Kidney-Metabolic Health Initiative is made possible by founding sponsors Novo Nordisk and Boehringer Ingelheim, supporting sponsors Novartis Pharmaceuticals Corporation and Bayer, and champion sponsor DaVita. Today's program is centered around these three learning objectives: gaining foundational knowledge of cardiovascular kidney metabolic or CKM syndrome and more, increasing confidence in applying key steps of the CKM care model, and learning about the American Heart Association's resources for implementation. It is now my pleasure to welcome our three distinguished speakers. Janani Rangaswamy is a nephrologist and professor of medicine at the George Washington University School of Medicine. She is a clinician researcher with expertise in cardiovascular kidney medicine. She is the immediate past chair for the Council on Kidney and Cardiovascular Disease of the American Heart Association and led the AHA Scientific Statements on Cardiorenal Syndrome 2019 and the Cardiorenal Benefits with Newer Anti-Diabetic Agents and Kidney Disease 2020. Dr. Rangaswamy has authored several publications in cardiovascular kidney medicine and is the lead editor of 2 textbooks in this field. She has won several awards for teaching and leadership in her career. And outside of her academic work, Dr. Rangaswamy is an Indian classical musician who has performed professionally widely. Welcome, Dr. Rangaswamy.
Thank you so much. Pleasure to be here.
Dr. Chiadi Ndumale is the Director of Obesity and Cardiometabolic Research and Associate Professor of Medicine in the Division of Cardiology at Johns Hopkins University. Dr. Ndumale is a preventive cardiologist with doctorate-level training in epidemiology who leads a research program related to characterizing the relationship of obesity and cardiometabolic risk factors with the development of cardiovascular disease and to refining strategies for cardiovascular disease prevention. Dr. Ndumale received his MD from Harvard University and his internal medicine training at Brigham and Women's Hospital. He served as a member of the writing group for the 2018 AHA-ACC guideline on the management of blood cholesterol and is presently vice chair of the Council of Lifestyle and Cardiometabolic Health of the American Heart Association. He cares for patients with cardiovascular disease in the coronary care unit and outpatient cardiology clinic at Johns Hopkins. Welcome, Dr. Ndumale.
Thank you for having me.
Our third speaker today is Melissa McGuire. Melissa McGuire is a recognized leader in cardiometabolic health and diabetes care with over 30 years of experience in clinical practice and program development. She serves as National Director of Program Development, Health Science at the American Heart Association, where she advances evidence-based models and professional education. In her current role, she also leads efforts on CKM certification, both nationally and globally. Previously, she directed the Cardiometabolic Center Alliance, fostering collaboration across more than 20 unique health systems, developing and implementing CKM centers of care. Melissa served on advisory committees for the AHA and ADCES and is a frequent speaker at national and international forums. Her work is widely published in leading journals, including JAMA, Circulation, and the American Heart Journal. Welcome, Melissa.
Thanks, Renee.
I will now turn the presentation over to Dr. Ndumale. The floor is yours.
Thank you so much. And I am very happy to be able to give an initial introduction to CKM syndrome assessment and care to set the stage for our case-based discussions. So I think we'll start with talking about the definition and the rationale for cardiovascular kidney-metabolic or CKM syndrome. And it can be described as a health disorder that's due to the connections among heart disease, kidney disease, diabetes, and obesity that leads to poor health outcomes. Now, importantly, from a rationale in terms of why we should be concerned about this is because these conditions really have a very closely intertwined pathophysiology, such that it really makes less sense to think of them as separate entities, but rather to recognize their interconnectedness. And because of growing rates of obesity and diabetes in the population, CKM syndrome is actually becoming the predominant cause or phenotype of cardiovascular risk in the population. And it has multi-system consequences, but the most significant clinical consequence is premature mortality that's mostly related to cardiovascular disease. So there's a lot of urgency around CKM syndrome, but there's also a growing scientific understanding, and we now have multiple new therapeutic options that substantially improve outcomes for individuals with CKM syndrome. So I want to highlight 5 key steps for applying the CKM care model. And this is what we'll be coming to as we're talking about our cases. Number 1 is systematic testing for CKM risk factors. Number 2 is CKM staging that provides a qualitative assessment of cardiovascular disease risk and helps to promote prevention across the life course. Number 3 is complementing this with a quantitative assessment of cardiovascular risk using the Prevent Risk Calculator. 4 is personalizing the clinician-patient risk discussion with an emphasis on risk enhancers that can help us understand people's risk of progressing along CKM stages. And 5 is holistically addressing CKM risk factors as they're identified. So starting with number 1, the reason for the routine assessments for CKM risk factors is really because many of these factors long go unrecognized or unaddressed. And chronic kidney disease is a great example where 90% of those with a diagnosis don't know they even have it. Additionally, the timely initiation of factors that when they develop is associated with improved outcomes. Now, in the CKM testing framework, we focus on the CKM stages, which I'll cover in a moment. And as you get to higher stages, you'll see that there's more frequent and also more intensified testing that is recommended or that is advised. And in those individuals who have existing cardiovascular disease, identifying CKM risk factors is really helpful for optimizing therapeutic management. Now you'll see there in stage 2 to 4, urine albumin to creatinine ratio is highlighted. The reason for highlighting urine albumin to creatinine ratio is because this is very complementary to the estimated GFR that we usually use to think about chronic kidney disease. And together, these are actually both part of the diagnostic criteria for CKD, either having albuminuria or having lower eGFR or the combination. And you can see from this KDIGO heat map with darker colors implying greater risk that those 2 parameters, albuminuria and eGFR, provide complementary information, not just about risk for kidney failure, but also for cardiovascular events and all-cause mortality. And you can see these individuals who are in the red are classified as very high-risk CKD for those adverse outcomes. And because those individuals with diabetes, hypertension, and CKD have a higher prevalence of albuminuria, that really justifies more regular testing there. Another thing that we need to be looking for in CKM syndrome is metabolic-associated steatotic liver disease, or MASLD. This is a leading cause of cryptogenic cirrhosis and need for transplantation, and it's very closely linked to CKM health. So 3-fold higher risk in those with overweight or obesity. And you see there's a spectrum from healthy to MASLD to MASH, metabolic steatohepatitis, and cirrhosis, where it gets irreversible injury. We want to catch people before they get to these later stages. And 70% of individuals with diabetes are in this inflamed MASH state. We know that lifestyle change and weight loss reduce fatty liver. And now we know that GLP-1 receptor agonists actually reduce liver fibrosis. So how can we catch people earlier? Well, one thing that we focus on is using what's called the FIB-4 index, using these 4 parameters here, and essentially looking at that every 1 to 2 years in individuals with diabetes or greater than or equal to 2 risk factors, CKM risk factors. And if it's greater than 1.3, in those who are 35 to 64 or greater than 2 in those who are greater than 65, that implies the need for more testing. Staging of CKM syndrome is important for detecting risk earlier so that we identify individuals earlier in the process and really promote prevention across the life course. You can see the stages follow the typical pathophysiologic progression for CKM syndrome. Stage 0 is people who do not have CKM syndrome. They have ideal cardiovascular health, and we want to help them stay there. Stage 1 is excess and or dysfunctional adipose tissue, which predisposes to stage 2, metabolic risk factors and or CKD, to stage 3 of subclinical cardiovascular disease or risk equivalents like very high risk CKD or high predicted risk greater than 20% using PREVENT. And stage 4, individuals with clinical cardiovascular disease overlapping with metabolic risk factors or CKD. So we really want to focus on using this to help us prevent CKM progression, to intensify therapy for those who are higher risk, and for those individuals in these earlier stages to promote going in the other direction with lifestyle change or weight loss, CKM regression. A complementary approach to the CKM staging approach is using a quantitative assessment of risk with the PREVENT risk calculator depicted here. So while the qualitative approach can tell us which risk factors are present and how far along this spectrum of CKM syndrome are we, and do we have cardiovascular disease, the quantitative approach can put all these factors together and tell us what's the integrated risk over 10 years. And if that 10-year risk is actually low, it can actually say, what is that risk over 30 years, particularly for younger and middle-aged adults? Number 4 is using risk enhancers to personalize the risk discussion. And these are conditions like chronic inflammatory conditions or mental health or sleep disorders, or being from an adverse social determinants of health context or having a high-risk demographic background that actually influence the likelihood of progressing along these CKM stages. So in discussing things with your patients, when we see these risk enhancers, that will make us talk about whether we want to be a bit more aggressive about preventing their progression along CKM stages. And number 5 is really moving beyond just thinking about individual risk factors alone for preventing heart and kidney disease, but then moving to achieving control of multiple interrelated risk factors for individuals with CKM syndrome. Here are the top therapeutic priorities: obesity, addressing that through multiple modalities, using cardioprotective glucose-lowering therapies in diabetes, blood pressure control, using kidney protective agents, and then lipid-lowering therapy according to the degree of cardiovascular disease risk. Now, one more very important point is the impact of fragmented care. As you all know, so many of these individuals with multi-system disease are seeing multiple different providers. If you have heart failure and CKD and diabetes, you're seeing primary care, cardiology, endocrinology, nephrology, and it's really easy for things to fall through the cracks and for everybody to take a bit of a siloed, especially the subspecialist, siloed approach to care. The problem is that's going to be hard for patients to navigate, and sometimes they hear different things from different providers, and sometimes people are not taking responsibility for therapies with multi-system effects. Importantly, we need to move from our siloed approach to a patient-centered, harmonized approach that focuses on what the patient is seeing in front of us, these interrelated conditions, and focuses on coordinated and affordable care and the broader social context. We really emphasize the use of interdisciplinary teams with a CKM coordinator to really support this approach, and we'll talk about that during the cases. So to finalize, this is the highlights of the algorithm for CKM stage 1 to 3 management. So when we see complement risk factors, we want to focus on interdisciplinary care. There's also going to be a focus on addressing social determinants, both screening and addressing those, addressing CKM risk factors holistically, addressing obesity through multiple modalities, and then thinking about what comorbidity somebody has for which cardioprotective antihyperglycemic agent you want to use. And then preventing CKD progression in individuals who are higher risk. Then we're going to think more like that stage 3 population about intensive therapy and combination therapies to reduce their risk of progressing to cardiovascular and kidney disease. In CKM stage 4, here, that by definition, there's already confluent risk factors among these individuals with cardiovascular disease present with either metabolic risk factors or CKD or both. We want to again focus on interdisciplinary care and addressing social determinants. We want to address obesity and cardiovascular disease. And here we have more data around obesity pharmacotherapy improving outcomes. Addressing and controlling CKM risk factors, using cardioprotective antihyperglycemic agents in those with CVD and diabetes, and preventing CKD progression with these agents that we know are helpful for improving both kidney disease and cardiovascular risk. So in summary, this brief overview just highlights that CKM health reflects the interplay among metabolic risk factors, chronic kidney disease, and the cardiovascular system, and that there's a need for holistic care approaches to mitigate the multi-system morbidity and the greater risk for mortality inherent to CKM syndrome. Optimal CKM syndrome care includes 5 steps: systematic testing to detect CKM risk factors in a timely fashion, qualitative risk assessments with CKM staging to promote prevention across the life course, quantitative risk assessments using the Prevent Risk Calculator to give additional information about risk, personalizing the risk discussion with CKM risk enhancers, and then holistically addressing interrelated risk factors within CKM syndrome. So that's a brief overview. And now we're going to move to some cases. I think some questions are already coming in. We're going to work to address as many questions as possible as we discuss these different cases. So please continue to put those questions in and we will continue to address them. But Janani and Melissa, I see you're back here on video. So we're going to go ahead and get started with, we have 3 case studies we're going to go through, and I'll be the narrator for case study number 1. So this presentation is of David, a 45-year-old man with a history of overweight and stage 1 hypertension with systolic blood pressure in the 130s. He comes to the cardiology clinic for the evaluation of palpitations. Describes occasional sensation of brief palpitations that last seconds. He denies any chest pain, shortness of breath, or other cardiovascular systems and has no prior cardiovascular history. From a social standpoint, he's married with 1 child. He works as a contractor, and he describes some challenges with making ends meet. Doesn't eat many fresh foods, including fruits and vegetables. And in part, he describes this as due to cost considerations. And he smokes 3 to 4 cigarettes a day. Is not currently taking any medications. Before we move to his evaluation, Janani or Melissa, anything you want to point out that you see in terms of his presentation?
Thanks, Chiari. I'm happy to start. And Melissa, please weigh in. I think this is such a great example of just bringing it all together in that CKM health framework, right? Baked into several risk factors that stand out: stage 1 hypertension, coming with some non-specific cardiovascular symptoms. You're right after that, you're seeing the fact that he is a smoker and also detecting that there is some level of adverse social drivers of health and some financial challenges that may also be influencing its care. So I think it's just, again, putting, the need to kind of zoom back and take that holistic approach right away, within a few minutes of the case.
Yeah, and I agree. I think it's a great patient to highlight, stepping in sooner rather than later. Face value doesn't have a lot going on, but this is the type of patient we want to see that we can start that CKM holistic risk and education on. So great one to start with.
Yeah, and I love the fact that it's not a super concerning cardiovascular presentation,
Yeah.
but represents an opportunity, regardless,
Yeah.
to still make sure we're taking a look at what needs to be addressed. So let's go to the next piece, which is the evaluation. So on examination, David's body mass index is 29 and a waist circumference of 106 centimeters. His blood pressure is 138/86. His heart rate is 77. You can see his jugular venous pressure is normal at 7. His lungs are clear. He has a cardiovascular examination that's pretty normal and has a protuberant abdomen, which is soft. His extremities are warm without edema. He has distal pulses of 2 pulse. So his labs are notable with an eGFR of 55, potassium of 4.2, glucose fasting of 118. You see the total cholesterol of 184, HDL 38, triglycerides 123, and LDL 121. A hemoglobin A1C in the prediabetes range of 6.1%, a UACR that's elevated at 212, and an eGFR that shows a sinus rhythm with some PACs and nonspecific T-wave changes. And when his prevent score is calculated, and it says that that is 9.1 for 10-year prevent CVD risk. So, Janani and Melissa, what stands out to you here?
Several things. Clearly, there's evidence of overweight when you look at just the excess adiposity piece, but clearly on exam and confirmed with the waist circumference is the visceral adiposity component. This is such a key part of the stage one, and the fact that there's overlapping excess and or dysfunctional adiposity across the whole spectrum in CKM, and further highlighted and amplified by the Lancet Obesity Commission report as well. So I think that's a very key aspect that will require a non-judgmental approach to the discussion and also an intervention early, to Melissa's point, when thinking about prevention. Certainly, from a laboratory perspective, there is evidence of kidney disease. Now, technically, chronic kidney disease implies at least two measurements were performed and at least 90 days apart. But for the sake of discussion, let's take that at face value that this is CKD. Now, when you look at his GFR, he is in that stage three, CKD eGFR range when you look at the KDIGO map, but that's a broad range between 30 to 59 cc. So he's on the upper end of that spectrum. So that puts him at CKD 3 little a. So that's the nomenclature. When you look at the albuminuria, he's got 212 milligram per gram. So that puts him in the A2 category. So right off the bat, this comes under high risk CKD. And Shadi, to the point you made earlier, that's not just for kidney failure. That's for all-cause death, cardiovascular deaths, the whole spectrum of all phenotypes of cardiovascular disease, ASCVD, heart failure, peripheral arterial disease, and kidney adverse outcomes. And on top of it, given that he has stage 1 hypertension, appropriately, his 10-year prevent CVD score has been calculated as advised by the 2025 AHA-ACC blood pressure guideline, and it is above that cutoff point of 7.5%. In addition, there's also evidence of metabolic syndrome. So I'll stop there, Melissa.
So, I mean, you hit the nail on the head on all of those different aspects. My angle coming at it from maybe a care coordinator type position is, did the patient even know he was living with all of these risk factors, and really needing to assess that, because he came in for heart palpitations, but now we're talking about his kidney status. He may or may not have known he was living with prediabetes. We're going to tell him to stop smoking. We're going to tell him that he needs to control his blood pressure. So you really need to have that full 360 scope of what did he understand and where do we need to go from here.
Yeah, I think this is a really helpful case because number one, this is a patient, as you said, Melissa, that represents that 90% of people who don't even know that they have chronic kidney disease, and in this case, high risk chronic kidney disease based on that UACR. And I think on top of that, the idea that we think about educating and activating him, but then also think about, okay, what resources do you need to help you once you're motivated and activated to achieve better kind of lifestyle modification. So I think this is really key. So let's go to the next piece here. We're going to go through one by one, and then we'll try to answer some of the questions from the audience as we go along as well. So 4 questions. First, what stage of CKM syndrome are we in based on what we've seen so far?
Yeah, I can take that. So there are 2 ways to quantify how he enters into CKM syndrome staging. This individual has stage 2 CKM syndrome. If you just take the kidney piece alone, just by virtue of the fact that he meets that high-risk CKD categorization, David finds way into stage 2 CKM. But even if you took the kidney piece out, he meets the definition for metabolic syndrome. He has 3 out of the 5 components. So independent of his kidneys, he would still land with stage 2. So I think one point to appreciate here is that there are several components within CKM syndrome stage 2, and these are deeply interconnected, so patients can find themselves into that stage across multiple pathways.
Okay. Melissa, do you agree?
I do agree. Yes.
All right. Good. We have harmony here. Multidisciplinary harmony. So what factors influence your approach to his blood pressure management? And I imagine there's a couple things here. So I'll leave it to you all.
Okay. Yeah, Johnny, I was going to say, Johnny, I'll defer to you because this is in your wheelhouse.
It's in everyone's wheelhouse. Yes. This is a team-based approach. So yes. Right back at you, Melissa. But I'm happy to start, and Chiadi and Melissa, please weigh in. A couple of things for the audience to consider, given we are a few months out of the new guideline, the 2025 updated blood pressure guideline. And in the previous slide, you saw that Dr. Ndumale showed this individual's prevent CVD score. And what is important to appreciate is this represents the risk for total cardiovascular disease, not just ASCVD. It's ASCVD plus heart failure. So this is a relatively young individual in his mid-40s, and the guidance is that if you have stage 1 hypertension, remember David's not on any therapies, And that total 10-year CVD score is above the cut point of 7.5%, which it is here. That is a push, that's a 1A recommendation to initiation of therapies, as opposed to being below that threshold where there is some leeway with 3 to 6 months of initial lifestyle and diet. Now, this does not undermine in any way the importance of lifestyle modification in David. Several aspects need modification. The lowest lying fruit and the highest yield is smoking, counseling, and cessation. That's a huge one. Also for the blood pressure, but for everything, his whole health. And then there are evidence-based diets like the DASH diet, which are therapeutic in themselves, as in, even up to anywhere between 6 to 10 millimeters of systolic reduction with implementation of diet. Caveat here, though, is that you also have to examine the possibility of adverse social drivers of health. It's very easy to say, go eat the DASH diet. What are you going to do if this individual is struggling with food insecurity? But three, since we've made that decision already, both based on his comorbid kidney disease and that preventive greater than 7.5%, one, we would treat and preferentially initiate a RAS inhibitor, an ACE or ARB, both given that he also has that high risk, kidney profile and he has albuminuria. Melissa and Chet.
Okay. No, that's good. We want to
Yeah.
make sure we get to all the different pieces. So let me ask one more question. Well, this is going to be for you, Johnny. How do we characterize and address his kidney disease?
I'll be very brief here because the kidney piece is going to come up in other cases as well. As we already spoke, he's in the high risk category. He is in the G3A and A2. So there's a lot of risk modification and albuminuria reduction that is going to be necessary. But first and foremost, addressing the blood pressure and the albuminuria, RAS inhibition right off the bat.
Yes, that's great. So, now we know based on the prevent, based on, that he needs to be treated, but then the question is what with, and the RAS inhibitor being a key consideration there. And then we'll get to the next one, which is what aspects of his social context should be addressed, and then we'll address some of the questions in the chat.
And I think Johnny actually made reference to some of these, but he's already said that he may have some issues with some food insecurity, those types of things, doesn't know really how to work these changes into his lifestyle. So really finding that support, that education, and potentially any of those social programs in his area that could be beneficial to that, and not just assuming that we're going to hand him a diet and have him walk out the door. Know how to do that, how to attain the right kinds of foods, and really getting him connected with some support and some education is going to be key, especially since he's likely having no symptoms at all. And he's walking into this appointment not on any medications and is probably going to walk out on several. So acquiring those meds, being able to afford them, and then this whole new lifestyle really is going to require some hand holding and some coaching.
Excellent. So let me quickly address a few of the questions in the chat. One is that for patients with stage 2 CKM, would they likely all need FIB4 screening? I think the majority of them will. And on that time frame that we've talked about, if you have diabetes or have 2 or more, which most individuals have, CKM risk factors in stage 2, that will be the rationale for doing that and screening at that interval. And then subsequent testing, we'll talk about that more in the next case. ICD codes are not yet available for CKM syndrome. That typically follows guidelines, and the AHA-ACC have announced that during the first half of this year, CKM syndrome guidelines will be released. So I suspect that the approach for potential guidelines will follow from that. And of course, that billing and then guidelines will help with, I think, some of the medical pieces that are asked about in terms of access. UACR is recommended for individuals now based on the hypertension guidelines who have hypertension. So basically that by itself would be an impetus, and it's in stage 2 based on the hypertension beforehand, actually, for being able to get that. So that's a reason to measure that possibility. And then the final question here is CRP. I think that's very reasonable. CRP could be a very reasonable thing to address here. It does co-localize with metabolic syndrome and with metabolic associated steatotic liver disease. And we consider that a risk enhancer for CKM syndrome progressions. That would be very reasonable to measure as well. All right. Thank you for that robust discussion, and I'll make some quick take-home points. So basically, the pharmacologic management of stage 1 hypertension is going to be indicated for those who have a prevent greater than or equal to 7.5 for the 10-year score, and for CKD. Also, For RAS inhibitor is going to be recommended in the context of hypertension and albuminuria. We talked about actionable, clear lifestyle guidance to improve street treatment success, especially for asymptomatic patients. We talked about patient education and the importance of that for the various risk factors and not forgetting the smoking and other pieces that are very important. And then even during a routine cardiology visit, the importance of incorporating UACR and thinking broadly about CKM risk. And then SGLT2 as an addition to RAS inhibitor for the management of CKD. You mentioned that, right, Johnny, as well? And I think that's even in the absence of type 2 diabetes, if your albuminuria is high. Would you recommend starting with an ACE inhibitor or an ARB in this case? I think you could use either, but many people push towards an ARB to minimize the likelihood of any side effects, but I think both are possible here and have equivalent benefits in the absence of side effects. All right, so going to case number 2, Johnny.
All right. Thanks, Chiadi. So I'll present quickly case 2 and get your input. So this is Michelle, a 56-year-old woman presenting for the evaluation of progressive fatigue and dyspnea over 6 months. She now has dyspnea with climbing 1 flight of stairs or carrying laundry. She's also developed lower extremity edema and 2 pillow orthopnea. She has a history of obesity, hypertension, and prediabetes. She's a single mother of 3 children, takes the bus to her job in retail. Her symptoms have recently made her commute and standing at her job challenging. She does not smoke or drink alcohol. Her 2 medications include valsartan, 80 milligrams daily, and amlodipine, 5 milligrams daily. Next slide. All right, let's quickly look at her clinical data so that we can open it up for discussion. So her BMI is 42 with a waist circumference of 118 centimeters. Blood pressure today is 142 over 88 millimeters mercury, and her heart rate is 82 beats per minute. Her JVP is 12 centimeters. She has basal arousal and auscultation. She has an occasionally irregular rhythm, normal S1 and S2. Her abdomen findings are significant for mild hepatomegaly and epigastric discomfort with deeper palpation. She appears well perfused and she has 2+ edema. Labs are notable for an eGFR of 52 cc's per minute, a potassium of 4.5, a fasting glucose of 122 milligram per deciliter, total cholesterol of 176, and HDL of 52, and triglycerides of 112 milligram per deciliter, and LDL of 102. Her A1C is 6.7%. She had a UACR measured, which is wonderful because most people don't, and this is 52 milligrams per gram. She has a pro BNP of 320. She also had her FIB-4 index calculated, and it is 2.3. Her ECG is mostly notable for sinus rhythm, left atrial enlargement, and occasional PVCs. Her echo shows mild concentric LVH, an increased LA volume, an EF of 60%, evidence of grade 2 diastolic dysfunction, and an EE prime of 20. So Chiadi, I'm going to open this to you. Can you put some of these findings in context, both from her symptomatology and her notable CKM risk factors on labs and those findings on the echo?
Yeah, thank you. So there's a lot to be concerned about here. First, in terms of her presentation, coming in with progressive fatigue and exertional dyspnea and orthopnea and lower extremity edema, that really makes me worried just by the presentation about the possibility of heart failure in this scenario, especially in the context of having multiple CKM risk factors. And I think we'll talk a bit more about the fact that her social challenge situation is also probably a little bit challenging here as well, and makes it going to be a little bit difficult with engaging with and navigating with multiple aspects of care. So she could probably use support, and also seems almost at risk of losing her job, which will make things even that much worse on top of everything. From an evaluation standpoint, looking at this severe obesity is a real question mark, especially with the substantial both general and abdominal adiposity, big risk factor for HFpEF in particular. The elevated JVP, the lower extremity edema, the hepatomegaly, epigastric discomfort, all make me think of the same stuff. And then she has uncontrolled blood pressure, which is also going to exacerbate things. So all those things stand out to me, in addition to the fact that there's high risk chronic kidney disease based on her eGFR and the G3A range, as well as the elevated UACR. Her proBNP, she has diabetes now. She, at least, while there's only one measurement, you need more than one measurement, but at least it's in the diabetes range for her A1C. And or proBNP is not always elevated in the context of HFpEF, but it is here, and that's a good marker for congestion. And then we can, Melissa, I'll leave it to you to say something about the FIB-4 index if you'd like, because I think that that's a really powerful piece that we're seeing here along with everything else. But from the echo, I'll just say briefly that she has very much a HFpEF echo, that left atrium being enlarged, LVH, high E to E prime that reflects LV filling pressures, and a preserved ejection fraction. She probably has pulmonary hypertension. It all goes along with that syndrome. So very important presentation. Melissa?
Yeah. Well, and as you said earlier, when you first started the conversation out, it's not really surprising that she has a positive FIB-4 given all of her other metabolic and cardiovascular risk factors that she has going on. And so at this point, with a FIB-4 index greater than 1.3, we are going to suggest, and guidelines suggest, that you do some initial checking out with VCTE or elastography. So there will be additional steps to go ahead and see if we can codify her liver stiffness and see extent of fibrosis should it be there. So just another testing, another layer to add to this complex patient's case.
That sounds great. Thank you both. That was very insightful. Chiari, based on her clinical presentation and the natriuretic peptide and the echo, would you give her a formal diagnosis of heart failure, and what stage CKM syndrome would you put her at?
Yeah, so actually, I should probably take you to the questions here, but I agree. So I think first of all, her stage of CKM syndrome here is going to be stage 4, and it's important that not everybody has to have all of the other conditions. You can have obesity with HFpEF. That context that typically goes together very frequently. So I think stage 4 CKM syndrome, and your second question beyond the stage was.
Yeah,
Oh, the
and if you're,
definition
yeah,
diagnosis.
a
Yes, I think
diagnosis of HFpEF.
she
Yeah.
definitely has enough for the
Yeah.
diagnosis there. HFpEF can sometimes be difficult to diagnose, and we have a score that they use called the H2FpEF score that you could use, and she would be very high from that standpoint in the almost definite for having or high risk for having HFpEF. So I think she's a very clear candidate for that clinically.
That's great. And then building on that, if we move to the next step, what are some of the primary therapeutic considerations in terms of guideline-directed therapies with this new diagnosis of HFpEF?
Yes, so I think that that's really important. I think that this is somebody who FPEP used to be an area where we didn't have as much that we could do. Blood pressure control and decongestion would be the mainstays, but I think now we have a lot more that we can do therapeutically that can support her care. So first of all, I think an SGLT2 inhibitor is where we have some of the most data right now in terms of improving HFpEF outcomes in this population. So that will have dual benefits here. It will help our heart failure and will help that CKD as well. So I think that it'll be kidney protective and reduce that albuminuria. The second piece here is that I think given how severe the obesity is here with a BMI of 42 and waist circumference of 118, this is a really great place to talk about using a GLP-1 or GLP-1 GIP agent, which have been tested in clinical trials like STEP, HFpEF, and SUMMIT. And with SUMMIT, with tirzepatide, showing a substantial improvement, 38% reduction in heart failure events, worsening heart failure events with that therapy. So a really good benefit there, which will also help with the weight and also help with the glycemia and have some effect on the kidneys as well. But then I think the third option, that's where I would start. But a third option to consider would be the non-steroidal mineralocorticoid receptor antagonist finerenone, which also has benefits in those individuals who have HFpEF based on most recent trial data.
Yeah, I think that was really comprehensive, summarizing the current evidence for GDMT in the HFpEF space. And interestingly, all three of those classes also have benefits on the kidney aspect. Melissa, you had already touched a little bit about the FIB-4. So talk to us now, thinking of the multi-organ benefits and the concern, on top of her having steatotic liver disease, what would your approach be there?
So we talked about, Chadi's approach would actually help all of those aspects too in that liver aspect. We want to control things like hypertension and other risk factors. Glycemic weight obviously is going to be a big one for this patient. All of those things in that treatment of potentially steatotic liver disease. And so I think that combination therapy with the weight loss, the risk factor identification and modification, as well as getting the weight off of her, are going to be probably the big key things we can hone in. But I think first and foremost is a recognition that we need to take that testing further and pulling the liver into this construct of this cardio-kidney metabolic space, I think is going to be number one, and then educating the patient on that as well.
That's great. And then finally, to conclude, clearly social adversity is also very front and central to this patient's life story. And notwithstanding the fact that we're talking about combinations of therapies, there's going to be financial considerations. She's a single mother, multiple children, and very symptomatic. How do you visualize care coordination in this very complex patient who truly will benefit from this very intensive approach?
I think the number one thing is educating the patient themselves to be the best advocate, because she's likely to see multiple care teams, and we're all going to need to be on the same page. And so she's going to need to know what her care plan is so that she can share that with her care team members as well. But I think really key is communication with the patient, and then communication within the other care teams as well. Hey, I'm seeing your patient. I'm starting around multiple agents, and using those key phrases for CKM risk reduction so that everybody knows why we're jumping in with both feet here, is that this patient is a hallmark CKM patient with multiple comorbidities that need to be addressed immediately.
Yeah, sounds great. We'll just take one question here from the audience because it's relevant. Chiadi, there's a question about, would you initiate empagliflozin first or finerenone, or would you initiate them together?
Yeah, I mean, I think my general, especially when it's going to be a lot thrown this individual at the same time, the order I went in is the order that I would take. I would start with the SGLT2 inhibitor that is the kind of longest track record in terms of data here now in HFpEF and benefit from a CKD standpoint. And she also now has the A1C was higher as well into the diabetes range. And then I would move to the GLP-1 as my second agent just because of that obesity and the MASLD and everything else. So I think that's the order in which I would take things just based on her risk profile.
Sounds great. Thanks for that engaging discussion. And in the interest of time and to have an equally robust discussion, let's summarize the take-home points. Obesity, kidney disease, diabetes, and hypertension are not just key risk factors, but also are therapeutic targets in the management of heart failure with preserved EF. The assessments of liver fibrosis and MASLD is a very important component of this individual's care outside of just the C and the K and the M elements. Several CKM therapies clearly have overlapping benefits. You just heard a great discussion about that. And there's no better example of how important care coordination is here, not just for the heart failure, but also the multiplicity of organs that will benefit, and also the clear lack of social support in this case. So thank you both. Great discussion. And I think we can now move over to our final case 3. Melissa, take it away.
All right. Thank you. So I have Miss Maxine, who is a 58-year-old woman presenting to an outpatient cardiology visit, and she was referred by the ED after she had severe incidental CAC score finding on a chest CT for pneumonia. She has a history of obesity, diabetes, and hypertension. She has a family history of kidney failure and heart disease. She's married with 2 kids, has a long-time job as a busy administrator, and really doesn't have much time to take care of herself, although she does not smoke or drink alcohol. Her current medications include atenolol 50 milligrams, metformin 1,000 milligrams, and atorvastatin 20. So on examination, her BMI was 38 with a waist circumference of 104. Blood pressure is elevated at 142/88. Her heart rate is 72. She has a JVP of 8, and her lungs are clear to auscultation. Her cardiovascular exam shows regular rate and rhythm, S1, S2 with an S4. Her abdomen's protuberant and soft. Her extremities are warm. She does have a trace edema, but her distal pulses are 2+. Her labs were notable, quite notable, for an eGFR of 38. Her potassium was 4.6. She has a fasting glucose of 214. Her total cholesterol was 188. Her HDL-C was 41. Her trigs are slightly elevated at 163. And her LDL-C is 114. But of note, she did have an LP(a) available, and that was 156. Her hemoglobin A1C, unfortunately, at this time is 9.6, quite elevated. And her UACR is elevated as well at 324. She had a FIB-4 index of 1.1, and her ECG showed normal sinus rhythm without ischemic changes. Her 10-year PREVENT CVD score is calculated at 41.4. So there's a lot going on with this patient as well, and I think I'll just kind of open it up for a really brief kind of overall view from each of you, and then we'll dive into some specific questions. So Chade, if you wanted to start maybe with just an overall kind of view from the cardiovascular risk, and then we'll talk to Jonathan about the kidneys here in a second.
Yeah, so I'll just be brief and say there's a lot going on, and a lot of it was happening under the radar, right? So
Yeah.
that severe incidental CAC means that her CAC score is likely in the hundreds, 300, 400, maybe 1,000, depending on how severe it is. And these are the things that are under the surface contributing to that for her. It's also probably important to say that she, while social history has been, or adverse social determinants has been a risk enhancer for the earlier cases, here we have family history as well.
Yeah.
There's an additional risk enhancer, and that's kind of positioning her to be further along. And she hasn't really been engaged with her health. So there's a lot here to be able to do to maximize her health with uncontrolled diabetes, very high risk chronic kidney disease, and also the obesity and uncontrolled blood pressure and lipids to be controlled. So, Johnny, what do you think? I think there's a lot happening here.
A lot happening here. And again, in the interest of time, we don't have to go through all of that. From the kidney piece, I will point out, so this patient's GFR is in the range of CKD3B, and in the albumin area, they're in the severely elevated category of A3. And like you rightly said, Chiari, puts this individual just based on that in the very high risk for death, cardiovascular adverse outcomes, and for kidney failure. That 10-year prevent CVD score is completely not surprising. In these patients with very severe kidney disease, that 20% cutoff is almost the floor of the range of risk.
Yeah.
It's not the top, it's everything above that 20%. So the fact that it's twice as high to even make the cut for very high risk, not surprising at all.
Yeah.
Yeah,
Yeah.
definitely. Let's get into some more pointed questions. So, Johnny, what is Maxine's stage of CKM syndrome?
So based on the kidney piece, she's stage 3 CKM. As you can see
Yeah.
in that figure, in the bottom piece, there are two equivalents. One is the prevent score of greater than 20. She already meets that, as she clearly also has evidence of subclinical cardiovascular disease, which is what brought her in the first place on imaging, and then the kidney piece. So she has stage 3 CKM written all over.
Yeah. Thank you. And then
And also the prevent score and the CAC.
Yes.
So all of
And
it.
then
There's
all
three
of them
criteria.
together. She meets practically every single criteria.
Yes.
Yep.
Well, and then Chade, how do we address her risk related to her type 2 diabetes?
Yeah, so it's really important to recognize. So in secondary prevention populations, they have a risk of about 2% per year. So this prevent risk of 40% is saying like 4% per year. This is above the average for what you would think about for somebody who has existing CVD. This is where we want to be really aggressive because of the imminent risk. So this is where I would say I would very strongly consider dual therapy here with a GLP-1 receptor agonist, which will help reduce cardiovascular risk, but also help with the weight, help with the glycemia, help with kind of improving that aspect, and have some kidney effects. And then the GLP-1 that will also, sorry, the SGLT2 that will help with reducing risk and also reducing her kidney disease, particularly, and future heart failure risk. I think this is a good scenario where a complementary approach for the various comorbidities and high risk may be appropriate.
Yeah, and Janani, we already sort of talked about her addressing that risk for CKD. Chade has said it right out of the gate, SGLT2, GLP-1. Anything else you want to add in at this point?
When you consider, just anchoring on the kidney piece, the overlap here is between type 2 diabetes and kidney disease. There are 4 evidence-based pillars of therapies that all have foundational effects in reducing cardiovascular outcomes, adverse outcomes, and kidney outcomes. So RAS inhibitor, still very relevant and still generic, cheap, readily available. So we shouldn't forget that. But clearly immediate use of SGLT2 plus GLP combinations. In this individual with a UACR of greater than 300 milligrams, it's very plausible that even on that, the patient still has evidence of residual risk for progression, anything above a UACR of greater than 30 milligram per gram. And that's where the addition of a nonsteroidal MRA, finerenone, which has a label for this, would also be a consideration.
Perfect. And then Chade, we saw that, she had an elevated LDL and a quite marked elevated Lp(a). So how might we work with those, given the fact that she has such a high risk presentation with some of these other comorbidities, along with those elevated cholesterol levels?
Yeah, so this is a scenario. First of all, we should emphasize the fact that lifestyle modification is a really important key here. And I think educating around the risk and helping people understand my patients where they have this presentation of this degree of subclinical coronary disease, it often is a very big motivator. And I think that that's a really important thing here. But I think from a therapeutic standpoint, beyond lifestyle modification, we really need to get that LDL down to the level we get it down for people who have existing cardiovascular disease. So I would say This is where she's on a low intensity or moderate statin. I would put her on a high
Mhm.
intensity statin. I would put her add ezetimibe for sure. There's recent data suggesting that this is a population where we may want to be even more aggressive and think about additional adjunctive therapies to get them down below 50. But I would say at the very least, to try to get to that LDL of less than 70 would be, I think, appropriate in this scenario. And I think also, I just don't want to forget about the blood pressure here as well.
Yeah.
The blood pressure was a bit uncontrolled and needs to be addressed. I think the RAS inhibitor that we talk is going to be helpful for the kidneys and for the blood pressure again in this scenario.
Great. And then how would you care coordinate? I know I've talked a lot about care coordination, we all have, but it'd be interesting from a provider perspective of how you would do that care coordination and how you think that might impact her clinical management. So either one
Johnny,
of
you
you,
want
I'm
to
gonna,
start?
Sure. And I think that's always the unspoken, detail that gets left out. We come up with such granular plans for here's what we're doing for UACR, here's our plan for the excess glycemia, here's our plan for every other possible risk marker. And the biggest risk staring at our face is the fact that she has all these social adversities. And this is where I think, in the advisory, there's a call to action for that coordinated care and actually designating a point person in that role. It is simply impossible to expect that a whole variety of a set of specialists and different people looking at their piece of the puzzle, much as they would like to take that holistic approach, you really do need a designated person just heavy lifting all this fragmented care that's happening. And I think that's the model that we're moving towards. Chiari, any additional thoughts?
Yeah, the one thing I would say is I think this is a journey. There's so much to do here. I don't try to, wouldn't want to do this all at once, but then there's a lot of follow-up needed. I think this is where the CCAM coordinators that are part of this initiative will really be able to, the CCAM work will really be able to help somebody along that journey. And I think the navigation across so many different providers is going to be a real key here in terms of thinking about this piece as well. So I think this is where there's a lot of different therapies, there's a lot of different goals. Taking it step by step and helping them along the journey, I think will be
yeah.
helpful. I think we have
Well,
some
and
questions we can
yeah,
address.
to your point, we just had a question come in, and I think you spoke to this a little bit, but maybe go into a little further nuances. For this patient, how fast would you implement those 4 pillars of care? How quickly do we want to move on this patient?
Johnny, I mean, I'll take a quick step and just say initially, I think the important thing here is even for the kidney components of this, the cardiovascular risk is what's going to precede everything. So we want to get things on board as soon as possible because there's a very imminent risk for cardiovascular events here. So this is not something I'll be doing over a couple of years. I'll be doing this
Yeah,
over weeks to get them where we need to get in terms of getting them to goals. So those diabetes therapies, I'd start pretty quickly. And Johnny, I imagine what's the time frame where you think about augmenting the kidney therapies further?
So that's actually that's a great question because it is a current gap in our knowledge. When you talk about the 4 pillars of therapies in this patient with that overlapping diabetes and kidney disease, there's really no precedent to tell us how quickly they should be
yeah,
implemented. And, we know how to assess residual risk, but at the current pace at which it is represented in guidelines, it can take 2 to 2.5 years to get people on 4 therapies while they're dying of cardiovascular disease, to your point. So this is an area where I think there will be some implementation trials testing what an accelerated risk-based approach would look like, but we truly, from a kidney perspective, don't have an answer.
yeah,
In a disease-adjacent state with HFrEF from the strong HF study, we do know that there is a very early separation of survival curves just with 2 visits separated by 2 weeks in those with HFrEF for quadruple therapy. So, that is one model we have, but we can extrapolate that to every
yeah,
disease state. But I agree with the urgency that you outlined, Shadi.
yeah. Perfect. And kind of wrapping it up. So for diabetes with a high risk CKM risk, considerations for the use of combination, and Chadi, you brought this up right out of the gate, both that GLP-1 receptor agonist and SGLT2 inhibitor, especially with multiple uncontrolled cardiac kidney metabolic risk factors like this patient had. And those living with diabetic chronic kidney disease with albuminuria associated with a high kidney and cardiovascular risk, that 4 therapeutic options that we just talked about to help reduce those risks. Also, for patients with an elevated A1C level, kind of wanted to put a note in here for maybe some anticipatory guidance regarding an elevated risk for genital mycotic infections when initiating some of the glucose lowering medications that we see. We know that those patients may be more prone to genital mycotic infections if their A1C is very high, and we're bringing that down. So really do some of that anticipatory teaching to mitigate some of those side effects. Also, severe CKM syndrome is associated with a greater risk of ASCVD. So consider that aggressive lipid lowering therapy that we talked about. And then finally, high risk patients seeing multiple clinicians, potentially in this case, an endocrinologist, nephrology, endocrinology. We talked about the really ground level need for that CKM coordinator, really painting the picture to help this patient be successful. So I think that wraps that point up. And I think we're going to toss it back to you, Renee, to see if there's any other questions.
Thank you all for that engaging case study review. And we do have several wonderful questions coming in from our attendees. You all have answered a few of these along the way. So here's our first one. Waist circumference measures abdominal obesity. Compared with BMI, the waist to hip ratio is a better predictor of diabetes and cardiac disease. So why aren't we considering waist to hip ratio?
It's a great question. Waist to hip ratio is a great measure. The challenge is on the population level, it's very difficult to implement, and there's a lot of inaccuracy in how it's implemented at that level. So we get a lot of error from a measurement standpoint when it's not done in the context of controlled research studies. So for something that's more accessible, but still gets at the concept of abdominal obesity, then that's why the waist circumference alone is what's emphasized. But if you're agile at doing that, measuring that additionally, there's nothing wrong with it, but it's harder to implement at the population level.
Wonderful, thank you. One that kind of, reflecting back on all the cases that you just reviewed, one of our attendees asked, how does classification of these patients with CKM syndrome change your approach to the management of those 3 patients?
Who wants to start?
I'm happy to start. I think that there's the value of having that CKM staging, system is to keep emphasizing at every stage, one, that there is an evolution of the interconnectedness of these factors and how they affect end organ and cause end organ damage. It provides that qualitative piece. It allows you at a population and systems level to zoom out and take the 10,000-foot view, because those on the right-hand side of that figure, stages 3 and 4, they may represent a very small chunk of the population numerically, but they are the ones with the highest rates of adverse outcomes and the biggest consumer of healthcare resources with poor quality of life. Catching them on the left-hand side of the same figure that you saw is where there's the most opportunity for prevention of progression and aspirationally regression as well. So at whichever way you want to look at it, from the prevention side to how to allocate resources, like case 3, where we just saw, whether you're, sitting in the C-suite of a hospital, whether you're running a group practice, whether you're talking to the individual patient in front of you, and you're motivating a young person to quit smoking and take ownership of their life. I think it applies all across that risk spectrum.
Wonderfully said.
It looks like we have time for one more question. So this is an interesting one. The question is there value with coordinating dental care, as periodontal disease has shown to have an impact on managing diabetes, CVD, and CKD?
Yeah, Melissa, I don't know if you have thoughts about this, but I definitely think it's a very important piece. It's a very substantially a challenge in patients with diabetes in particular, and it's definitely associated with greater cardiovascular disease risk. So and other multi-system risks as well. So I think that is a very important aspect. That oral health is a very important aspect of our care. Melissa?
There is. Well, actually, at Sessions, went to an abstract that talked just about that and where they were doing CKM, almost like staging at dental health appointments and finding cardiovascular risk with those patients. So that's a wonderful question and something that we really do need to spend a little bit more time on, because that risk factor is there and that correlation is important.
Thank you. And I want to thank all of the attendees for these excellent questions. And even though we didn't have time to answer every single one, we will be reviewing them and sharing with our speakers. Thank you again to our wonderful speakers, Dr. Ciotti and Dumile, Dr. Janani Ragaswamy, and Melissa McGuire for leading today's case study discussion. This webinar is part of the American Heart Association's Cardiovascular Kidney Metabolic Health Initiative, and we invite everyone to use this QR code here to visit the page for more information and resources. Our call to action for all of you today, for all healthcare professionals, is to follow these 4 steps: to become familiar with the CKM Science Compendium, including the Prevent Calculator, to be a champion for CKM care at your healthcare organization. And based on the questions, we're seeing that many of you are already doing that. You do have the opportunity to comment on draft standards of care for CKM Center certification. We'll share a link in just a moment. And also, we encourage you to download our CKM implementation guide for access to tools and resources to adopt this model of care. All of this is available using the QR code. And lastly, here is the QR code for commenting on our CKM's draft standards. Again, we want to thank all of you for your participation in today's event. After today's webinar, you will receive a follow-up email with the survey on the presentation, and we'd really appreciate it if you would complete it and provide your feedback. Again, thank you to our distinguished speakers and everyone involved. On behalf of the American Association, this concludes today's presentation. Thank you and have a wonderful day.